as Jill said, and thank you, Jill, for reaching out. I unfortunately did not make it easy for her to get a hold of me. I was all over the place, so thank you. It was interesting when she asked me to come and talk to you guys again. I wanted to put together a completely new presentation. And in the process of doing that, I realized how important some of the information was here. And so I chose to update this with some very new technologies and new techniques. And I'm going to spend a little bit more time on that than I traditionally would, because I think it's just such a game changer. The last 3 years has, even though unfortunately COVID and the pandemic had occurred, it really stirred research in very specific areas. So I'm going to spend more time with that because I think it's directly relatable to you guys. So let's get started. So we'll talk about, I got to get used to looking down. So I want to talk about specifically the management of pain in acromegaly. Now, there's not a lot of good literature out there looking at interventional pain management and pain management in acromegaly. And that's unfortunate. And I hope conferences like this will stir my colleagues to really start looking more into it and coming up with more specific guidelines and things that we know would work more in your community. So a little bit about me. I am an interventional physiatrist. And so most people don't know what a physiatrist is. And I always tell them that's a good thing, because if you do, I'm sorry. That means something bad happened. So basically, I'm a muscle, bone, nerve, and joint specialist. Okay. And physiatrists understand both sides, which is the physical medicine portion of it. So the diagnosis and management of physical problems, and the rehabilitation side. So the type of disabilities that come along with these type of problems and ways to manage that. I'm fellowship trained in interventional physiatry, so I use minimally invasive interventional techniques and minimally invasive surgeries to help treat and diagnose these problems. So we're going to talk about, in general, these four areas: pain, acromegaly and pain management specialist, and lastly, pain treatment options. So the first thing, and you guys have seen these slides before who have heard me talk, but it was so crucial. I can never get away with this, and I got to tell you, get away from this. And I use these next few slides in a lot of different presentations I do. And so the first thing is, who has pain? What is pain? Now, it seems like such a basic question, right? Because we all have had some experience of pain. But the truth is, what most people call pain, they don't really understand what it is. So I'm just going to ask you guys, just blurt out. Tell me, what do you think pain is? Anyone? Yes, sir. My mother-in-law. His mother-in-law. I share your pain, sir. Anyone else? Yes.
It's a fifth vital signs. So for nurses, you ask, heart rate, temperature, and all that, but you ask them the fifth one is what's your pain level.
So the fifth vital. What else? What do you guys think? Give me some. What do you think? Discomfort, sir. Yes, interruption and quality of life. An alarm, absolutely. I love it. Anyone else? These are all perfect, and you're absolutely right. But what I want to say is, I want to ask this question. Is this person in pain? Not yet, but I'm going to argue the fact, yeah, there's some pain going on. And I'm going to explain in just a moment why. What he hasn't experienced is something else. Is this pain? Now, the question is it pain because this crab is pinching his nose? Is that pain? Would you say my nose pains? Or would you say my nose hurts? It hurts. But you all just said, yeah, this is pain. But you didn't look at the crab. You looked at his face. So hurt is what your body experiences. Pain is what you experience. Pain is you as a sentient, conscious being responding and expressing to hurt. And I'll go through that one more time because this is crucial. This is a crucial point. So hurt is what your body experiences. Pain is your response in essentially how you outwardly show that. So in the previous slide, I said, well, maybe. Now you can't see too much, but you can kind of get the gist. He's a little scared. This guy's running. He's about to be in a world of hurt, but he's running, right? He's experiencing pain, whether it's discomfort, whether it's fear, whether it's the fact he's regretting having played with that crab, right? So to me, when I think of pain, this famous painting by Edward Munch, The Scream, just really just hones it down. If you look at it, this is a beautiful day. So you can tell it's either sunset or sunrise. There's people walking down this boardwalk. It's on water, possibly. It's kind of serene if it wasn't for this ghastly character. And it's not the disfigurement, right? It's the facial expression. This is chronic pain. Now, in this one, a lot of people who have studied this painting will say, well, this is depression, right? This is an artistic impression of depression. And I'm like, it's pain. And so pain essentially is your emotional, psychological, intellectual, your social experience of hurt. It's going to interrupt your ability to perform your activities that you want to do. You know, you can't pick up your kid. You can't go to the movies with your friends. You can't have intimacy with your partner. You can't go out and go for a walk. It interrupts all these things. You got to plan around it, right? All of a sudden, there's the intellectualizing. Why, maybe if I do this or that. There's even God dealing, and that's an actual term where you're like, well, maybe this is happening to me because it's a test by God or what have you. There's some sort of spirituality that people assign to it versus, emotional, right? Fear, depression, anxiety. We know there's an 80% associative rate of depression and anxiety with chronic pain. So when I think of pain, I understand that it's all of you. It's not your jaw. It's not your headache. It's not your wrist pain. It's not your back pain. That's your hurt. Let's improve your hurt, but we also got to address your pain. Because even after you get rid of hurt, the pain a lot of times still remains, right? The fear of it coming back, or the sense that now you're vulnerable, right? Or what did I do to deserve this? Am I being punished? Right? And so it leaves scars in your person. Any questions about that? All right, shall we? So this is just a basic slide talking about the impact of pain in the US. And really, it's an extremely common problem. In fact, when you look at healthcare dollars, it actually takes up a substantial amount of the healthcare dollar. And the amount of people who present to their primary care doctor with a complaint of pain, it's actually pretty significant. It's one of the top 4 reasons for a visit. And so here you can see, and these numbers are kind of older. This is from 2006. I mean, you can see $303 billion of the healthcare dollar in relation to GDP. That's huge. And then, I mean, you can see it there. 1% of US GDP in 2013. I mean, it's a huge cost. And so there's a lot of research going into it. And that's why we're constantly seeing new techniques and new tools to treat this. So this slide basically looks at some of the symptoms specific of pain in patients who suffer from acromegaly. Okay. So one of the very common ones, as you can see here, and I put little stars next to it, is headaches, arthritis. Now, and I'll talk just a moment about what this arthritis is, carpal tunnel, and I put obstructive sleep apnea with a star in next to, for reasons of discussion of pain. Again, we are a conglomerate of many different things, Okay. And we're not just a bunch of little isolated systems that are kind of connected. We're not. We're one person composed of many interacting and connecting systems that for essentially, we divide, but they're all continuous. And so one thing affects another. So sleep apnea, we know, has a whole host of problems. It can perpetuate blood pressure issues, weight gain, daytime fatigue, and excessive sleepiness, right? Irritability, eventually increased problems with depression, decreased threshold in pain. I mean, think about it. You didn't get a good night's sleep. How's the next day? You feel great? You kind of feel icky, right? You feel like your body just kind of doesn't feel good. Now imagine extrapolating that over weeks, months, your pain threshold decreases. So one of the important parts about pain management, which we'll talk about in just a moment, is, again, holistic, comprehensive approaches. You got to look at sleep. People get better night's sleep. They report less pain intensities. Now, kind of going back up, obviously headaches, a big one. And when I said about arthritis, we're talking about osteoarthritis. And so osteoarthritis, very quickly, is very important when it comes to headaches. And it comes to some of the other pains highly associated or found in patients with acromegaly, because essentially it's a malformation of the joint. That's what arthritis is. We have these very nice, when we're born, very nice, smooth joints, and they have a very specific shape. And over time, that shape starts to change a little bit, and with the associated ligaments and all the soft tissue in it. And that leads to changes in how the joint functions and can cause all sorts of problems. And that's important to keep in mind as we go through the slide, because I'm going to talk to you guys about what we can do about that, And obviously, one of the problems in acromegaly is there's a change in the shape of joints. So I like silly slides. And I want to talk about myths, okay? I love this. This used to be my hamster, by the way. No, he lived a very full life, trust me. But he would do this, and I always thought he was doing little sit-ups, It wasn't. He thought, he realized that if he kept doing that, I gave him treats. So he kept getting fatter instead of more abs. So I want to talk about myths, and myths are really important. In my years of treating patients with chronic pain, it's amazing to me when they come, all the preconceived notions they have. And those preconceived notions, most of them came from either friends, family, or other treating physicians. And a lot of times these myths impaired their ability or impeded them from seeking out care, sometimes for years. So some of the most common ones that I found. One, no standard of care to treat pain. Not true. Fear of addiction to pain medicines, and we'll talk about this. Patients just have to live with their pain. There's a little bit of truth, but the majority of that statement is wrong. And all patients with pain have psychological issues. Well, if you didn't have a brain, you wouldn't experience pain, right? So yeah, and like we just said, pain is a response to hurt in your body. So there is some psychological response, but not the way that's meant, right? You're not crazy because you have pain. So, and I don't want to beat you guys down with too much definitions, but chronic pain is a nauseating stimuli that you've been experiencing for longer than 6 months. That's the definition of it, right? Some sort of discomfort or something that's a nauseating stimulus to your body. And that's been going on for longer than 6 months. And typically we try to, in science, we're always trying to label things and categorize things. So we've basically broken down pain into 3 types of pain. Nonconceptive pain, which is like an ACL tear or a rotator cuff tear. Neuropathic pain, nerve pain, and then mixed pain. The truth is, all type of pain is mixed, all right? Because if you don't have nerves, you can't perceive your pain. And so, it's on this gradient. Some is more neuropathic or nerve pain, and some is more, some are more nonconceptive pain. And so on some gradient, it's not always equal, but this is important because when we start talking about different treatment options, medication, this is hugely important because this opens up a whole host of opportunities on how to treat this. So nonconceptive pain, essentially, like I've explained to you, is and I've given some examples here: sprains, TMJ problems, inflammation, bone fractures, burns, bumps, bruises. That's what's nonconceptive pain. And this is really important because this is basically an inflammatory process. This is inflammation. Inflammation is painful because it produces very specific proteins in your body which further promote inflammation. So inflammation causes more inflammation. So it's a cycle. And when you're talking about chronic pain, which is really what we're talking about here, so actually, believe it or not, chronic pain, one of the things we know is that there's a neurologic mediation, meaning there's some neurology that's driving some of that inflammation. Your brain and your nerves are telling some of the inflammatory markers in your body, hey, go here, we have a problem, we have a problem. And there's this continuous inflammation. But that inflammation is also signaling your brain and nerves that there's a problem. So it's a vicious cycle. Okay? So it's a problem of inflammation. Keep that in mind. Inflammation so far. That's very important as well. Neuropathic pain, like I just said, is essentially nerve pain. So in nerve pain, that's one, the sensation of numbing, tingling, burning, ants, creepy, crawly. Sometimes numbness is a form of pain. And this is basically a product of either the nerves in your extremities that are outside your spinal cord, or actually, believe it or not, it can come as a problem from your spinal cord in your brain, your central nervous system. So essentially, here are some examples: carpal tunnel, which is very common in the Acromegaly society, right? Calsalgia, or complex regional pain syndrome, which is basically when you look at your nervous system, there's two parts: the central and the peripheral. So the central is basically your brain and spinal cord, and the peripheral, all the nerves that go into your extremities and into your organs. And you can further break them down, but in the peripheral nervous system, you can have a dispairing of two parts of it called this parasympathetic and the sympathetics. And that can cause this condition. It's extremely painful. And I've had a couple of acromegaly patients who have suffered from that as well. Peripheral neuropathy. So basically, it's an injury to the extremity nerves. And we can see this with diabetes. And we know that there's an increased risk of diabetes with acromegaly. And so you have these confounding problems. Post-Herpetic Neuralgia. Again, this is when you've had shingles and the shingles resolved, but you still had that pain. Big problem. Phantom limb pain as well. And this really goes to home about how neuropathic pain, how nerve pain works. Imagine you have a pain in your foot, a really bad pain. It's deformed and skin breakdown, and there's all sorts of issues. And unfortunately, you lose your limb. But the pain remains. Think about that. The source of pain, the source of that hurt is gone, but yet the pain remains. Okay? That gives you an idea of the power of neuropathic pain. And that's how I'm telling you, it's always mixed. So that's just very important when we, again, start talking about medications, when we start talking about opportunities to find ways to treat this. Because if we don't treat the nerve portion of it, it's very difficult to treat the other portions of it. And essentially, I don't want to beat this down again, but this is essentially what I've just been saying, that all these type of pains are mixed. So a common question I get asked is, well, is there a lab? Is there some sort of objective test to measure pain? The answer is no. We don't have a lab that can say, aha, you have 6 out of 10 pain. That doesn't exist. One, because pain is your experience to your hurt, right? So what's your 6 could be very different than your 6. And that's very important. So it's placed in the context of that person's individual experience. When you talk about visual analog scales like this 0 to 10, And it's interesting. I always give the example. I had this patient, a very sweet old lady, and I saw her for years for some arthritis on her back. And I would see her every month because I had to give her some very specific type medications that we can only give in 30-day increments. And she would always tell me, oh, I'm about 4 or 5. Okay. Weather got a little worse. The weather, this is in Michigan, so weather's always getting worse. And, kind of go up to 6. And one day she comes in, and just to paint a picture, she's a small, just cute little, if you can imagine, a church lady with her little purple hair and her little vest. I mean, she's adorable. And one day she just says, 10. I'm like, 10? What's wrong? So on the way to my office, she got pulled over and got a ticket. First time in her life. And this whole visit, she was just telling me about how rude this. And she said cop, which was funny to me. I hear her say cop, right? She's like, this cop, he pulled me over and gave me, can you imagine? And she was so worked up over this that she perceives her pain as a 10. Now, that doesn't mean that 10 was erroneous. What that really exemplifies is the impact of your emotional state to how you perceive pain, right? Because you're at a party and you're having a great time. You just won the lottery. Someone says, what's your pain level? You're like, -10, right? I'm going to Vegas. So pain is your personal experience to your hurt, right? Emotional, psychological, spiritual, social, all these different aspects of what makes you a person's response to hurt. But we don't have a specific laboratory test. We don't have a specific way of saying this is how much hurt you are in. And just one other point on that. Sorry, this just went off. Another point to this, which is very important, is that what you see on X-rays, MRIs, ultrasounds, and for the medical in the group and watching, very important take-home message. What you see on these diagnostic tests do not tell you the type of pain the person's in. I'm going to repeat that. What you see on X-rays, CAT scans, MRIs, EMGs, blood work does not directly correlate to patient symptoms. I've seen multiple patients with fractures in their spine with 0 symptoms. I've seen MRIs and X-rays who the person's spine, you can't even make out the anatomy because of how much osteoarthritis, but yet they have no pain. And you're like, are you sure? Yeah, they're fine, right? Some of my farmers in Michigan, oh my God, and they're 80 years old and they're strong as oxes, and they came to me for something different. And I happened to get an X-ray, and I'm looking at this like, I'm pretty good at anatomy, and I'm having some tough time picking out some anatomy here. How severe the arthritis is, and they have 0 symptoms. Yet on the same side, this is really, really important. I've seen people with normal MRIs in a lot of pain. So if the person with a really bad diagnostic test has no symptoms, are they lying? Do they have pain? They just don't want to tell me? Because if you think that the person with a normal MRI has symptoms and they may be lying, then you have to apply the same logic to the person with a really bad MRI who has no symptoms. Does that make sense? What you see is not what you get. I usually use the example of a car. I like to use a lot of analogies with my patients. And it's like you have this car, you open up the hood, and the engine's a little rusty. Would you buy it? Not buy it? Right? You're like, I don't know, I'm going to test drive it. Because all of a sudden, that rusty engine, you may pay $100,000 and it's a rat rod. Right? Or it could be a junker. You don't know until you try it. And so what you see on test does not tell you about pain. And you can't, and it's not a direct linear correlation, right? There's tons of people, as a nurse, you see people who have X-rays with pneumonia, but no symptoms. Or you have people with symptoms of pneumonia, but their X-rays are clear. It's called clinical pneumonia. So I want to get into the management of pain. Now, first and foremost, When people think of pain management, they always just think of pills. Okay. So when it comes to pills, we've come a very long way. All right. The last century, we went from essentially a handful of different type of pills, which were essentially all but a couple were opioids, which most people call narcotics, and then a couple anti-inflammatories and an analgesic, which is Tylenol. We've come a very long ways. And this is from a page from an old, actually medieval medical text. And they were treating here low back pain. And what did they do? They take a chisel and they make incisions. And that's how they treat low back pain. Now, the reason I want to bring this up and go into a little bit of detail about this, it's because our brains are wired in a very specific way. Your brains are wired in a way called gate theory. So if you've ever taken a hammer, and unfortunately not on purpose, I hope, hit your thumb with it, what's the first thing you do? You grab your thumb, right? Well, wait a minute. Why are you squeezing your thumb if it hurts? Right? Why squeeze something that hurts? It's because your brain can only really perceive the most intense pain to it at a time. So if you have a bunch of cuts or you have something like this going on, yeah, you're going to perceive this pain instead of your usual pain. Oh, I feel better, but this hurts more. Well, pay me your 2 chickens on the way out, or whatever they did back then, right? So, so that's important, and because one of the technologies we're going to talk about is actually based upon this. And no, it's not cutting you up and leaving you out. Although I have had a patient pay me with chickens before. I'm like, I don't know what to do. I mean, do we eat them? Are they pets? I don't know. I let the chickens go, but so this is basically from some guidelines that we have, and this is from our colleagues, the endocrinologists from their academy, and this is from the 2011 recommendations. And so the reason I'm bringing these up, it's not to bore you with scientific details, but rather to let you know there are guidelines. And when it comes specifically to pain, and I put little stars next to them. Now, the good thing is about these guidelines are they allow a significant amount of room, if gray or wiggle room, if you will, to help treat the individual person. Okay. Essentially, I get to be able to treat you the way I would any other patient. That's huge because that means I get to use all my tools. Because I always tell people there's only so many tools in the tool shed. And if you start taking out tools, that's a problem. Okay. You don't want me cutting your lawn with scissors. Not a very effective tool. So, by allowing me the opportunity to use all the tools in my shed, it gives more options on how to control the hurt that you're experiencing and improve your pain. Again, same thing. And this is specifically towards headaches and osteoarthritis, which we're going to get into in just a moment, why I mentioned arthritis and headaches and why they're so important. So one of the things that I want to talk about in terms of pain management is how important it is to control acute problems, and then later on how to control chronic problems. So when you're talking about controlling acute problems, it's if you let a problem sit long enough, it becomes chronic, obviously. And then when you have a chronic condition, the chronic condition will start causing other issues, will start to decompensate. So if we can nick things in the bud and squash acute flare-ups, acute problems, it will help decrease some of the chronic exacerbations and some of the things that chronic pain leads to. And this is really important. People don't realize this. When you're hurting, and you've been hurting for a long time, you move less. If you move less, you get weaker. If you get weaker, all sorts of other things happen. Like I mentioned before, blood pressure, weight gain, right? Depression, a whole host of different problems. Also, you start noticing that you start going to the doctor more because you want different things. So you start getting more tests. And it has this complete interruption in your life. So if we can try to get things under control sooner, the better off you are. And it's really important because a lot of times I see people say, well, I'll just wait. Oh, I'll give it some time. I don't want to just go to the doctor yet. I always tell people small fires are easier to put out than bigger fires. And that's part of some of the myths that we were talking about before, right? You don't have to live with the pain you have. There's always opportunities to improve. And one of the things I always challenge my colleagues and some of the residents I taught and some of the fellows I taught is, if you ever tell a patient there's nothing more I can do for you, you failed them. Unfortunately, and I'll say this tongue in cheek, evidence-based medicine has a lot of wonderful things that came with it, but some bad ones. And I'll tell you what some of the bad ones are. Thinking outside the box. Right? And so it's easy to say, well, I'm sorry, the medical literature states that there's really no other options for you. And, good luck to you. Talk about taking a bullet to someone's hope. Well, just because the medical literature doesn't show it doesn't mean you can't keep trying different things in conjunction with the patient. Because at the end of the day, we're not bound by any law that I can only do what the medical evidence says. There's a lot of medical studies out there that may not be the best evidence, but still gives me some opportunities of other things that other doctors have tried. They thought, well, maybe acupuncture, right? Maybe Tai Chi, maybe aqua aerobics, maybe using some different type of medicines that traditionally we wouldn't think about doing this, right? I make the argument, and a lot of my colleagues will disagree with me, and that's fine, but the advancements of medicine does not happen in the laboratory. It happens in private practices, right? Gabapentin, which a lot of you may be on. Originally, it was an epileptic medicine, and it was also a mood stabilizer for bipolar patients. Guess what? Some docs said, some of these people that have this nerve pain also says it makes them better. Let's keep playing around with this. And guess what? It did. It doesn't work for absolutely everyone. Nothing does. So the point is, with the myth, and I'll keep reflecting back on some of those myths as we move through the study, through the talk, you don't have to live with the pain you have. There's opportunities to improve. Improve is not 100%. There's also some importance to realistic expectations. I never tell people, I'm going to make you 100% better. I'd be lying to them. Okay. And this kind of goes back to kind of connecting myths and how our bodies heal and the importance of trying to get problems under control as soon as possible. I always tell patients, the body does not fix itself. It heals. And the two things are very different. Fix is like when you take your car to the mechanic and you got to change the alternator, right? They change the alternator and the car's fine and off you go. Well, your body does not work like that. Even if you get a new hip, a new shoulder, a new knee, whatever it is, you did not fix the problem. You only help the body heal. Now, heal is basically the restoration of your function to its maximum mobility within the constraints of the injury. So let me put that in some examples. You sprained your ankle in high school. Did that ankle ever stay the same? No. Let's say you're a pro athlete and you've sprained your ankle. Guess what? You're very aware that the performance of that ankle is not the same as it was before you sprained it. 20 years down the road, still not the same. Doesn't mean it still hurts, but you realize its tolerance for certain activities is less. You realize that it feels like it's easier to give out, that's easier to sprain. Why? Because the way our body heals is through scarring. So whenever you have an injury, your body produces inflammation, and that inflammation causes scarring. Scarring is not as good as the tissue it replaces. So there's little tears and all this stuff. The body will then, in those little tears, lay down scar. And scar, people think like a scar in your skin, right? Skin. No, it's not. Scar tissue is scar tissue. And the best healed scar tissue is only 80% as tensile strength as the tissue replaced. And it doesn't have the same endocrinological functions as the tissue replaced, which is why someone who's had a heart attack, the problem with heart attacks, besides the obvious, is there's scarring that occurs in the muscle of the heart. And that decreases the ability of the heart to function. So we heal through scarring. So what we want to do is limit the amount of scarring that occurs. So the sooner you get this, the sooner you get this taken care of, or you manage it, the less scarring, which means less impact on your function. Does that make sense? I just want to make sure, because that's a big one. People, and that's part of that management expectation. Yeah. Sure. So this is my own definition. This is my own interpretation of it when I kind of explain it to people. So healing is your body's attempt to restore maximal amount of function within the confines of the injury. Okay. Now that's not an academic definition, but in my quest to understand the body and understand pain, that really helps me put in context the importance of dealing with acute and chronic problems and trying to restore function and how I drive the treatment of patients' problems and their treatment. So again, I hope I've driven the point. Don't wait. The moment you start feeling something, seek treatment, okay? Because we got to nip it in the bud. So the other thing is, you don't want a one-man band. Okay, I don't care how smart I am. A one-man band, the one doctor says, I can do it all, right? The one provider who says that is not the provider you want. And I'm going to use a simple example. How many of you have ever seen a one-man band? They're cool looking, huh? I mean, they're talent. I could never do that. I mean, I play the guitar, and just the guitar alone, I'm like, okay, I better concentrate. I mean, they're playing the drums, the cymbals, the flute, and the harmonic. They're very talented. How many of you have ever been to a symphony or an orchestra? Does that sound the same as a one-man band? That orchestration of all those specialists produce sounds that poets have written about. I've never seen a poet write about a one-man band. Maybe Hemingway somewhere, I don't know. Absolutely. And that's an actually interesting point, right? Because you think about where you're going to get the better experience from. You think about what you're going to walk away with. So when you're looking at one-man bands, even though they may be very talented, you're not going to get the same experience as you do with a symphony. Now, the problem is if you have a bunch of specialists who don't know how to work together, I'd rather stick to the one-man band, because now you're going to get this disharmonious noise. So the key thing is you have to build a team to help treat your problems. Okay, your endocrinologist, your primary care doctor, which basically drives a lot of your care, right? Your neurosurgeon, your therapist, and I don't mean just physical therapists. I mean your psychological therapist, and I make it a point that any and all chronic pain patients should have someone that they see to help them with helping them develop coping mechanisms for the internal stress of chronic pain. That's huge. Your neurologist, your physical therapist, whether it's occupational therapist, your physical therapist, your recreational therapist, and if you live in some of the states where you have access to more public health driven systems, your public health nurse. So, and these people need to feel very comfortable communicating, whether they're communicating via email, phone, which, to be honest with you, most people do not communicate with phone because it's a lot easier to send a text or send an email, or especially their EMR systems. Yeah, if your EMR systems can communicate, because if you're in the OR and maybe the behavioral therapist wants to communicate with you and says, hey, listen, Mr. Smith is really having a hard time right now with X, Y, and Z. I really think you should see him. well, it's hard to pick up the phone when you're in the OR or you're with patients, but you can always see that email. So nowadays, communication is a lot more digital than just a phone call, but in a way that's better because now there's a string. Yes.
In my area, pain management specialists are overwhelmed with methadone patients.
Mm-hmm.
So I would not go to a pain management specialist, and I would not see that, I would not expect a pain management specialist to even communicate with my team. So
So
what would you recommend in that area?
yeah, so she's saying in her area, the pain specialists are overwhelmed with methadone. And that's a big problem. And she want to feel comfortable going to a pain management specialist. And that's actually going to lead, if you don't mind, because I have the answer to that question, but I want to talk about it in a different slide because I put it in context. Is that okay? Because that's a really important point, and we're going to talk about that. And there are all sorts of health care issues that are occurring because political policies and fiscal policies unfortunately influence care. And we'll talk about that. And so if I don't answer it, remind me, because I definitely want to answer that. But make sure as you're interviewing your providers, they understand your condition. They understand that you need them to talk to other doctors. Okay. So, and here's just again, a list of physicians. Now, talking about pain specialists, there's multiple different doctors who can become pain specialists. So as myself, right? I went to medical school, then I went to an internship, and then I did my residency in physical medicine and rehabilitation, and then I did a fellowship in interventional physiatry. Anesthesiologists can do the same. Neurologists can do the same. Neurosurgeons, orthopedic surgeons, believe it or not, psychiatrists can do the same as well. Typically, you're going to find either an anesthesiologist or a physiatrist who practices pain management. My advice is nowadays, unless it's someone who's been doing this for over 20 years, you really want to find someone who's fellowship trained in pain management. That's very, very, very important. Unfortunately, this is well, not unfortunately, but this is a much younger field specialty. And so a lot of people started in the field, and unfortunately, we're kind of just doing their best, but not with a lot of guidelines. And they started doing things that led to some other issues and led to specific government regulations, which have unfortunately interfered with the ability to adequately practice tailored specific medicine to individuals. So we'll talk a little bit about that in just a few minutes. But these are the type of doctors, specialists that you should be seeing. And my argument is, if it's a doctor who's graduated, or started practice in the last 20 years, they should be fellowship trained in pain management. Okay. And more than just spine, by the way. A lot of pain fellowships just concentrate on spine. You need more than that. Okay. You need someone who's actually practiced pain, who's actually been trained in pain management. That's head to toe. So let's get to how to do this, right? How do we treat this? Now, remember, back into the Academy's recommendations, for the Academy of Endocrinology's recommendations, I can treat the patient suffering from acromegaly like I would any other patient. So I get to apply this treatment approach. Now, this is from the World Health Organization, and this is how they recommend treating chronic pain issues and how to advance. So you start from the left and you work your way to the right. Now, I'll tell you, there's been some changes to this, some paradigm changes on how we approach. Part of it was politically driven, which I can tell you, I've been practicing long enough where I've come to realize that when politics gets involved with science, not very good things happen, right? And some of us have experienced that recently. But also it did drive some rethinking about how to treat chronic pain. And so when we get to this area here and here, it's kind of shifted around a little bit. So we'll talk about that. So essentially what they want you to do is they want you to start on the left, like I said, and work your way over here. And this is called the fan of treatment. So starting with NSAIDs and over-the-counter medications, first and foremost, these are not innocuous, okay? These are not just, it's over the counter. I bought it at Walgreens and I'm okay. I can take as much as I need. No. I can tell you tons of stories, and I won't bore you with a ton of stories of people getting themselves into a world of hurt and trouble just by taking these two. From kidney problems and heart problems to liver issues. In fact, I had one gentleman, I'll tell you this quick story because it's just some of the things you see, who found on the internet that you could actually crush Tylenol, which is acetaminophen, and snort it, and that would really help their headaches. And he did. And 2 weeks later, his doctor sent him to me, and he couldn't tolerate any light, and he had this horrible headache, and just when I was examining him, I saw his throat completely white, horrible thrush. But the way it looked is just very, very, very intense. And he didn't really have any real medical history per se. So, he wasn't immunocompromised or anything. And when I look into his nose, because part of headaches, which we'll talk about in the moment, there's over 200 different types. I'm like, is this a bad sinus issue? And there was erosion. I could see bone. And when I started asking him, his wife broke down. She's like, do you know what he's been doing? He saw on the internet this. And I couldn't believe it. And so I sent him to the ER and to the hospital. Unfortunately, he had tons of surgery. So, this stuff, just because you buy it over the counter doesn't mean it's safe, right? To use it just as needed. You have to follow the instructions. And even then, following the instructions, you have to be careful. So the second thing is there's a lot of other stuff out there that you can buy online. You have to be careful with how it interacts with your other medications. I've had a lot of patients who say, well, I prefer something natural, turmeric root. And you ask people, and they think just because it's a root, it's natural, it has no problems. Well, poison comes from plants, most poisons. In fact, if you've ever read Romeo and Juliet, they use foxglove. It's just a plant that grows anywhere. Okay? So natural doesn't mean automatically no side effects, no potential interaction, no pain. And no consequences. That's not the case. Okay, you got to be careful. It will interact. Like St. John's wort can interact with a lot of different type of medications. Anyone who's been on blood thinners, like warfarin, right, Coumadin, you can't even eat lettuce. Okay, there are a lot of interactions with stuff, so you got to be very careful. Now, I prefer, and I have no financial interest in any pharmaceutical company. I don't get paid by any of them, none of that. So just off the bat, but I prefer to be able to prescribe someone. If they're going to go down this route, I'd rather prescribe something that I know they have to take in a very specific way. Now, and I have highlighted here Celebrex. I like Celebrex because it's easier on the stomach. It tends to be better tolerated. And it has less interactions with other medications. And as an anti-inflammatory, it has a longer half-life. Now, when you talk about doctors, they'll talk to you about half-lives. As you all know, that's pretty important. And basically, that's how much of that medication stays effective in your bloodstream for about 50%. Okay? So I can give this to a person twice a day in adjusted doses and try and get nearly 24-hour coverage. And if you do this every day for a certain amount of time, you develop enough of the anti-inflammatory effect to really start combating inflammation. Now, remember before I told you that scarring can lead to inflammation. Inflammation can lead to scarring, and inflammation can also tell your nervous system, hey, I'm hurting here, and keep bringing and keep causing more inflammation. So that continuous production of inflammation, we have to fight it. So if you can use a very regimented, scheduled medication that produces enough anti-inflammatory effect for a sufficient amount of time, it can actually start reducing your inflammation, right? Now, this is not for you to stay on forever, right? We know that if you can cycle this, so on and off in certain periods of time, patients do better. So again, kind of what I mentioned, there are anti-inflammatory natural remedies, and I mentioned a few of them, and I prescribe them to patients. I tell them, look, go to your local health food store. I want you to use turmeric root or arnica, right? In fact, I like arnica a lot, for heel problems, for superficial joints, like for certain people, their knees or their ankles, or it works well. Liniment oil, it works on horses. right? I put CBD oils in there because obviously there's a lot that's happened in the last 10 years with cannabis and CBD and THC. And I get asked about this all the time. So the first thing I'll tell you is when you talk to your doctors about this, their opinion should be based on science. Okay? 2, Google is not Google MD. And I say that because Google presents a lot of misinformation. CBD, THC, marijuana does have certain potential side effects, does interact with certain medications. I can tell you CBD oils, I've had patients react to them. Bad skin rashes. And they'll say, oh, it wasn't the CBD, it was the oil. They tried different type of CBDs and they had some reactions, all right? I always use the example of something called an LD50. An LD50 is a scientific measurement that looks at how much of a substance do you need to expose to a population to kill off half of that population, right? That's the lethality of something. Water has an LD50. And without water, we can't live. There's no such thing as anything that is just perfectly safe, okay? It's important. I've seen people get themselves actually in trouble by drinking too much water, lowering their sodiums. So make sure you understand that with your medications, what you're putting in, even if it's natural, right? And I hate the term natural, that you have a conversation with your prescribing doctor about that. So again, I think I belabored that to the point, but it's important. And these things work. Okay, they're very good, and they can be integrated with your normal regimen, but it needs to be done intelligently and guided. Okay. So physical therapy intense. I have lots of patients who say, "Doc, I've already tried physical therapy. I don't want to do it. It doesn't work. It made me hurt worse." Okay. So first and foremost, let me use an example. Let's say I go ahead and I punch you in the arm, right, in both arms. And then I say, well, on one arm, I'm going to put a bag of ice, and the other arm, I'm not. And then afterwards, I'm going to ask you to curl. Which arm do you think is going to tolerate curling better? The one with ice or the one without ice? Right, the one with ice, right? If it's asking you to go and work out and activate muscles that are actively atrophied or actively guarded because it hurts, well, maybe that's not the best timing for physical therapy. Like anything else, timing is crucial. I prefer to have acute pain under better control and then have the patient go to therapy. Now, I always explain to patients the role of physical therapy. And physical therapy, and again, I'm just talking about physical therapy. When you look at occupational therapy, if you're looking at speech language pathology, recreational therapy, they all have, their timing is crucial, but they all come in at different points. I just kind of want to focus in on physical therapy right now. What I always explain to patients is the role of physical therapy is first to assess you, to evaluate you, and figure out what parts of your neuromuscular skeletal system are being affected by this problem. 2, identify the right type of movement to activate the supporting structures, the supporting muscles and ligaments. 3, to coach you, to develop an exercise program and coach you on how to do it. And then 4, make sure you're doing it correctly as a home exercise program, educate you on doing it, and then discharge you. That's the evolution of physical therapy, right? And that's crucial because we know, in fact, there's some interesting studies that came out of the 70s when they took athletes, college athletes, who had no problems, and they laid them in bed for 24 hours. They couldn't do anything. They just laid in bed for 24 hours. Imagine a bunch of college kids doing that. And they tested their strength before and after. And they realized there was a pretty significant percentage of drop in their strength to be able to recuperate that. I'm sorry, it's a significant amount of drop in their strength after 24 hours, and it took a few days to recoup. So when you have pain, you guard against certain movements. Your compensation, you change the way you walk, you change the way you pick things up. The way your muscles and ligaments and tendons are supposed to work in those joints change, and that can lead to weakness. And so we have to address that weakness. And a lot of people are like, oh man, I go to the gym, look at me. I've had professional bodybuilders with weak backs because the big muscles are strong, but the little muscles, which a lot of times are the ones that are the first ones to shut off, don't. All right. And that's what leads to all these tears, like rotator cuff tears and all this sort of stuff. So one of the most important things is first get the acute pain under control and then introduce therapy. So, and TENS units I like a lot. That one, it helps a lot. You have control over it. When you read the inbox directions, they say don't drive with it, don't do this, don't do that. I always tell people use it for half an hour. Make sure you tolerate it, make sure you know your settings, and then you can go to work with it. You can do what have you. There are some restrictions, but it can really help. So, other things, selecting the right type of therapy, the right time. We've talked about that. I get asked a lot about chiropractors and adjustments, right? Manipulation adjustments. It's helpful, okay? But you have to pick the right people. If you have someone that says, I can cure your cancer with manipulation, with adjustments, not likely the right person to go to, okay? They need to work within the confines of your treatment team, all right? And this is for any provider. So it definitely can help. It can help mobilize things. It can help realign certain issues. They have very good literature showing that it has widespread, comprehensive health benefits. Very important. But make sure it's someone that feels comfortable working in the confines of your treatment group. So other things, I mentioned acupuncture. There's lots of studies showing how acupuncture can help for very specific problems. That doesn't mean it can't help for other problems. It just simply means that these particular issues have been studied. I always tell people, if by the 6th session of acupuncture it hasn't helped, stop. And that's usually the case for a lot of things. Like if you go to the chiropractor, you go to your osteopathic physician, and by the 6th adjustment, it hasn't helped, stop. So acupuncture definitely can help with a lot of problems, with headaches, carpal tunnel, with knee problems, shoulder problems, right? Those muscle knots around the shoulder blades, which can trigger a lot of the headaches. That's very important. And so these are some other modalities that can help as well. And I just want to make sure we get to some of the other slides. So I was given a 1-hour cue, so I want to make sure we kind of get through everything. So complementary medicine, and we'll spend a little bit of time with this. So essentially, it's a misnomer, but it's looking at other things that can be added besides medication and therapy. So in here, I talked about looking at someone to help you with developing the internal coping mechanisms for your problems. And I have religious leaders here. A lot of people feel comfortable speaking to their pastor, to their minister, to the rabbi, to their priest, and they see them as someone they can speak to, that can get guidance and help develop some sort of psychological, spiritual, intellectual coping mechanism for what they're experiencing. And I encourage that. Whatever helps you develop that internal coping mechanism, as well as psychologists, therapists, counselors, mental health counselors, support groups. These things are important because if your emotional health isn't good, your physical health won't be either. Because remember, pain is your complete person response to that hurt you're experiencing. Relaxation techniques, huge. I can't tell you how often I have patients who actually commit to doing this, and they'll tell you it really helps. It helps mitigate some of the anxiety that pain produces. The anxiety of, oh my God, I'm going to hurt if I do this. Whether you're talking about Tai Chi, meditation, there's all sorts of different things. And you have psychologists who actually are trained in guided relaxation techniques. Yoga is a big one, by the way. I love recommending yoga to my patients, especially like, for instance, in the acromegaly community. A great one you should look into is chair yoga, like where you're sitting in chair. YouTube has a ton of videos, 10 to 15-minute videos. You can follow along. Usually it's an older lady with a cat. I don't know why the cat, but she's cute. And she'll, they have them for your neck, for your back, for your shoulders. And so you can follow along on YouTube. I always tell people more than 15 minutes is too much. Less than 10 minutes is not enough. So 10 to 15 minutes is a good thing. You can do it every day before you go to bed. So medications, and we're going to rush through this just a little bit. So there's a whole host of different type of medications. Okay. So we talked about anti-inflammatories, but nerve pain, right? Mixed pain has nerve components. So a lot of times I'll use things like Cymbalta, right? And they're like, well, wait a minute. I'm not depressed. I'm not here to convince you are. I'm here to say, well, guess what? This helps treat some of the nerve issues associated with pain. And this medication specifically had an indication for chronic low back pain. Yeah, it's an antidepressive medication because it helps calm some of the nerve portion of the pain. Neurontin, these two can be combined, and they actually are synergistic. They help one another. So I get to use this for both of these at lower doses. So I'm a big proponent of polypharmacy. You use intelligent, guided, different medications that can work together, that boost each other's activities, and that way you can maintain lower doses on each of them. And guess what? You really control side effects with this. If I know you have sleep issues, I know you have headaches, like in one of the headaches we're going to talk about. I know that you have some nerve issues. Well, I'm going to give you Neurontin at night, and I can use Cymbalta during the day. This tends to pep you up. And this tends to help you with sleep. So use the side effects to their advantage. And guess what? You tend to do better.
I take Celexa
Mm-hmm.
for depression, but I'll take it at night. Should I take it in the daytime?
Everyone reacts specifically different, and that's important to know. Because I've had patients who this puts them to sleep. It's not common. So if you notice, and essentially you got to listen to your body. If you notice it peps you up, take it during the day. If you notice it drops you down, take it at night. And really, you got to listen to your body. And because everyone's different. The populational studies, they do this in populations. And I can tell you X percentage of the population responds in this percentage way. But how do you distill that down to the individual, right? Your genetics are very different. Yeah. Muscle relaxers. This is a big one. A lot of people say, man, I'm so tight. I need a muscle relaxer. You got to be careful. Okay. They're good medications, but you got to understand their side effect profile. A lot of people will get Flexeril, which is cyclobenzaprine. This causes a lot of fogginess the next day. Now some people, it doesn't. But it's a cheap medicine, and that's why a lot of times that's what your insurance forces the doctor to use first. Xanaflex, I find, does very well. It's also known as tizanidine, right? It comes in 4 milligrams, 8 milligrams, and it helps with patients get to sleep, and for a good 5 hours usually, and it doesn't tend to give them fogginess the next day, but you got to be careful because there's some liver issues that you got to be careful with, right? Roboxin doesn't make you sleepy. You can use it during the day, but it won't really help you much with sleep at night. So being smart about what your symptoms are and having the conversation of what you're experiencing from your sleep, from your mood, and what have you will help drive some of this. Topical drugs, compounded medications can help a lot. We talked about arnica, but in certain places where they can compound medications with anti-inflammatories can help a lot and with very minimal side effects. The problem with compounded medications, most insurance will not cover them, unfortunately. Injections. So really quick, I want to make sure that you guys understand. I've had tons of patients who come to me and says, Doc, I've had injections, they don't work. And I'll say, what injections? They'll say, in my back. It's a cortisone. What type? It's like saying I had belly surgery. Are you talking about your gallbladder? Are you talking about your appendix? Are you talking about a tummy tuck? Are you talking about gastric? I don't know what, same thing. There are hundreds of different things that can be done to different areas. Injections are interventional, minimally invasive techniques. Okay. The first role of these injections is as a diagnostic. It's essentially to help prove where the problem is coming from. If I think the problem is, and I mentioned before facet joints, if I think the problem is your facet joint, which is a joint in your spine, and I think that's where maybe that's one of your primary pain generators, and I put medicine there, like numbing medicine, and about 20 minutes afterwards, you report a 50% reduction of pain in that area, that's diagnostic for that problem. And the literature says medial branch nerves. So those healthcare providers that are listening, there's other studies that show facet joints are equivalent to medial branch nerves, which is just a little nerve that goes to this joint. So if you block that nerve, a lot of studies say that should be the way you diagnose this. But the truth is, It's about the same. So these initial injections, the first time you have it, should be to help diagnose and prove the problem. And there's a whole host of different things, right? Epidural is very specific, and there's many different types. For my RSD patients, which we talked about before, this is not diagnostic. This is a form of treatment. And we'll talk about that in just a moment. So one type does not fix all. So my neighbor had this injection and it didn't work and it was horrible. Has nothing to do with you. Okay. Your butcher, your mechanic is not an expert in this. So if you're the type of person that takes financial advice from your mechanic, good luck to you. If you're taking, medical advice from, your bag boy, don't. Okay. What works for them or doesn't work for them has nothing to do with you, right? You guys come together so you can share your stories because you guys have one thing in common, right? And so that's very different than, the lady who suffers from rheumatoid arthritis. So keep that in mind. So these interventional techniques, and I've talked about this already. I talked about this already, how diagnostic tests don't tell the whole story. That's very, very important, okay? So someone says, my back hurts, I need an MRI. I need an MRI. That's going to tell you what's wrong. No, it doesn't. What tells me is physically examining you and listening to your story. That's going to create a list of diagnoses for me. And then I use diagnostic tests to either rule in or rule out that list of diagnoses that I have. And that's how your pain physician should be working. That's where they start. Listening to your story, really examining you, figuring out the different parts of your pain, coming up with a differential diagnosis list, which is what it's called, and then from there, working out. Not just say, well, I won't see if you don't have an MRI. If someone says that, don't see them. Okay? Because they're going to end up treating the MRI and not you. So I want to get into headaches. First of all, there's a international body that actually studies headaches. It's called the International Headache Society. And they produced this very, 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 very extensive manual on headaches. And the reason I want to hone in on headaches is because we know that one of the problems in acromegaly are headaches. There are over 200 different types of headaches based upon this, called the International Classification Headache Disorder, and they're on the 3rd publication already. And it spells them out very specifically, how to diagnose them and recommended treatment. Now, very common in patients with acromegaly are cervicogenic headaches. These are headaches that start from your neck. Neuralgias like trigeminal neuralgia, which a lot of time can be pain in a very specific distribution, like over your forehead and eye, or your cheek, or your mandible, or your jaw. TMJ headaches, a lot of headaches that start from that pesky TMJ joint. Tension type headaches, migraine, and specifically one I didn't put down here is occipital neuralgia. I can't tell you how often I diagnose that as the trigger headache, a headache that causes migraines, a headache that triggers trigeminal neuralgia. And we'll talk about that in just a moment. So when you're looking at headache, it's a combination of different things. From medications, the right type of medications. A lot of people say, well, I just need Emitrex. That works for me. No, wait a minute. That's abortive. That we're not really treating the problem there. Physical therapy. If we know that the problem can arise from your neck, let's look at what parts of the neck are causing it. And it's usually a combination of those facet joints, which are these little joints we have on both sides of our spine. They start from the base of our skull all the way down to our lower back. And believe it or not, the majority of back pain is actually caused by that, regardless of how many herniated discs you have. I always get people, I have 3 herniated discs. It's like they keep count. They're proud of their 3 herniated discs. I'm like, well, usually that's not typically the cause of your pain, your axial pain that you're feeling. And these type of joints can be provoked. You can exacerbate these symptoms. You can reproduce these symptoms very easily in the office. So believe it or not, when we do that, we now have a very specific way of treating it or diagnosing it and then treating it. And it's not just the MRI. So trying to get physical therapy to strengthen the little muscles that are weak around those joints. Lifestyle and diet modifications. There's a lot of things that we eat and drink that exacerbate inflammation, right? Sugary stuff, carbohydrates, right? So sodas and pastas. And there's certain types of food that we know are more prone to causing inflammation than others. I've had patients who have chronic headaches who I've asked them to change their diets. And I recommended one I used to recommend a lot was forks over knives. And it was actually, there's a Netflix documentary, and how many of these patients came back and said, Doc, I'm down from 16 headaches a month to 3, just from this one thing alone. Botox. This is a funny one. I always have the ladies, can you put a little bit here too? I'm like, why, are you hurting there? Yeah. Like, sure. So this is really for chronic management. The problem with Botox is it works great. It's really good. It's that your body eventually becomes immune to it, right? And sometimes it takes 5 years, sometimes 10 years. Your body can build antibodies to it, right? And that's not the case for everyone, but it can happen. Two, it's a bunch of pokes. Even though they're little tiny baby needles, it's 31 spots. You got to get poked. And sometimes you got to do it every 3 months, sometimes every 6 months. So when it comes to headaches, we have a lot of different treatments. I talked about radio frequency ablation before I get into the slide. And we're going to talk about that when we get towards the end of that fan of treatment. Facet joints, can cause these type of issues. Those little joints I talked about, recognize this one, C23. A lot of people complain, especially with acromegaly, about pain back here, that pain headache, that pressure that shoots to the top and makes you feel like you have pressure on top of your head and can wrap around over the ears and catch your eyes. Can come from that joint right there. Okay. C23, facet joint. And that can cause the occipital neuralgia, which causes that pain. Joints in your lower back. You know, a lot of people tell me, Doc, my hip. And in truth, it's a L5S1 facet joint with something called the Sacroiliac Joint. And it's just referring pain. And sorry, I'm rushing a little bit. I just want to make sure we get through all the slides. How are we doing on time? Okay. I want to make sure we leave time to talk as well and answer the questions. So, and this is getting more specific. This is what I talked about already, using these injections as a way to test these problems. So again, if I think it's one of these joints and I put numbing medicine there, now it's not just come in the office and take a shot, right? This is done under a very specific x-ray guided, and we put medicine in these very specific spots. We can see it and we measure your pain. If I ask you, hey, right before we do the procedure, what's your pain level from 0 to 10 in this area of the back, right? And we'll just go back to the previous slide. Let's say you're saying, man, my back is killing me right there. I'm like, okay, what's your pain level? 8. And I do this particular procedure, right? Put medicine in these joints, let's just say. And I ask you 20 minutes afterwards. And I'm not flooding the area with numbing medicine. No, I'm being very specific. And you tell me, you know what? Afterwards, it's a 1. You know what? It's numb. Wow. And they do this. Yeah, I don't feel it. Well, it's just got diagnosed. No different than if you go turn on your car in the morning and the car doesn't turn on. You think it's your battery. You change the battery, the car turns on. Well, guess what? Part of the problem was the battery. Okay, same thing. So, you know, sacroiliac joints, I find this common with acromegaly patients. Yep. And the truth is there's some interesting treatment for it that we can do for that. And it's a joint that's basically back here. Okay. And most people say, my hip. Here's something interesting. Your hips and your groin. Yeah. People always look at me like that. They're like, what? My groin. Your hip joints and your groin. Okay. When you have pain here on the side, which a lot of acromegaly patients have, that's actually a little bursa. It's a little sac-filled fluid. And it feels like there's a knife stabbing you right there. It's a bursa. It's not your hip. And that pain that you feel down here, it's actually your SI joint most of the time. So little tidbits to take away. So this is some new slides that I haven't shown before. We've, in the last, really, since 2017, we've actually become more aware of a type of pain called vertebrogenic pain. This is pain that comes from the actual bone of the vertebral body. The vertebral body is when you think of a vertebra, it's the front part, that big chunky bone. Well, at the top and bottom of that, there's a plate where the disc and the spine sit. And we realized that those plates get very inflamed, very swollen, and it's a source of pain itself. And what's interesting is we developed a technique to deal with it. That's pretty interesting. We actually there's a little nerve inside that bone that goes to the top into the bottom plates. And we can actually burn that nerve. And that sounds crazy and scary, but we actually do it with an incision that's less than a centimeter. And the effects are pretty significant. And this is called the Intercept Procedure. And so when you're looking at, when you have a change in the shape of joints, right? You have a change in the shape of bones, which we know is what happens in acromegaly. One of the things that can be affected are those plates, and that can lead, besides the joints I'm talking about, the facet joints or the SI joints or both, it can also lead to changes in your discs and changes in the plate where the discs sit, causing pain. And so I've been doing this procedure more and more. I find myself doing it more and more in patients that we had tried, treating some of these other things, and they still had this nagging. They got better, but they still had some other issues. And before, we just didn't have the tools to treat it. And this has been actually something pretty interesting. And we know about 15% is kind of what the literature shows of patients with low back pain who still have persistent low back pain after they failed these other or have had these other treatments. This procedure helps well for them. Intercept. Again, another new procedure called Cleris. So a lot of times what happens is the muscles that support your spine get weak. And that basically means the way you normally would move around changes a little bit and can lead to osteoarthritis. It also means that the structures that give support are weakened. Weakened supportive structures lead to more problems, and one of them are discs problems. So now we can go in with a little camera and we can go right down to the area that we think the disc is causing the problem. We can test that disc to see if that's the case. And then I can use a little camera with a laser to actually help reduce that little bulge or herniation or that annular tear, which is like a little paper cut on the disc causing problems. Before, you would have to get cut open and much more aggressive type therapy. Now we can do it with something that's the size of a 0.5 centimeter incision. And, it's done at surgery centers, but it's actually, it's pretty significant, the results. And I can use that same laser to help treat those joints as well, those facet joints you've heard me talk about. There's a little nerve that goes to them, and I can ablate that little nerve with that laser at the same time. So we've really come a long ways. And as medicine tends to move forward, what we're finding is less is more. Using smaller interventions, we're getting more precise outcomes. And it really has been impressive, the changes that have been occurring. I want to talk about PRP for a moment. It's called platelet-rich plasma. So this is something that's been around now for a while. There's a lot more studies coming out. Last time I spoke to you guys, there was the advent of more universities and more clinical studies looking at this. And really since then, there's been a whole plethora. So what this is basically we take your blood, we break it up into its components, we take the platelets in your blood, and we concentrate it about 8 to 9 times our usual concentration. And when we put that back in the plasma portion of your blood, and I inject it in a particular joint or ligament or tendon that has some injury. What this does is it stimulates the stem cells in your body to go there and help, 1, repair damage. 2, it helps restructure scars. Remember, inflammation, scarring. Well, scars are like sticky spider webs. So what we can do is we can reshape that scar using platelet-rich plasma. And the reason I want to tell you that we've had new advents on this is we've gotten smarter on how to do this too. And there's been a lot of other new products coming on as it relates to this. And so there's a company out there, and I'm not putting a plug for the company, okay, but they use a chorion and amniotic stem cells or product. And from here, these are volunteer patients who donate these products at birth, right? And we're not talking about fetuses or nothing like that. And they're all highly screened. And actually, they all come from Texas. And I'm glad you guys caught that. And so they dry and ground them up, okay? But guess what? It has a lot of stem cells. And when I combine it with PRP and I put in, like, let's say a shoulder that has multiple rotator cuff tears, or a knee that has, pretty bad arthritis, and the ACL and the meniscus are really worn, patients do fantastically well. And this is something that can be repeated. A lot of times patients, if it's the worse the arthritis is, the more likely they may have to have it repeated again. So sometimes you need a booster at 6 weeks. And I'll tell you, this technology really caught my eye. I used to practice in Flint, Michigan for many years, and Flint was really, hard hit with the economy. I mean, in 2008, Michigan was the only state that lost population, and the part of the state that lost the most population was mid-Michigan, which was Flint. And I was practicing there during the time, and I just have a real love for those people. I mean, talk about hardy. And these people working 70, 80 hours in these factories, and these factories are brutal. And man, I'll tell you, they'd save up, and I would charge them $600 because that's how much the kit and everything would cost me. It was that cost, and they'd save up their money. They come in once a year for it. That proved to me, I mean, forget medical literature. That proved to me the power of this, because of these people, that $600 meant a lot to them. If I could have given it to them cheaper, I would have. But it was powerful to see them do that. So it really does help. Does it help absolutely everyone? Here's a take-home message. Nothing helps everyone 100%. Okay? Any doctor or any provider that says that, find a different one. They're lying to you. Okay? It's important. Insurances do not cover PRP, so this is an out-of-pocket expense. All right? There's a lot of places, like I now live in Florida, and I'll tell you, I see colleagues charging $5,000 for this stuff, and it just breaks my heart. Because, anyways, it's expensive, but it doesn't need to be $5,000 expensive. So this is not me, obviously. This is a picture I took from the internet because I love her facial expression. So this is how I keep talking to you guys about how to use a machine, how an X-ray to guide me to those joints. This is that machine, and that's the other reason I like this picture. This is called the C-arm. It's a fluoroscope. It's something that can do live fluoroscopy, live X-rays, and we can use it to guide ourselves into specific joints. This is an old form of PRP. It's just I like the picture because you can see the plasma, you can see the platelets. So it's good for you guys to have an idea. And this can be done in the office, right? They break it down here, and it just gives you an idea. So this is that product I was telling you about, where amnion and chorion membranes, they basically take it and they create it into a particular form, and that can be injected with the PRP. Now, you don't have to use this. You could also use the person's own stem cells, right? They can, you can go into the belly fat and take some. And I always have women that tell me, well, can you take a lot? You're like, no, I'm not a plastic surgeon, but you do a little bit of lipo, you take it. Usually that's for non-smokers or people under 55. If it's older than that, or they're smokers, you go into the bone marrow, either the hip or wherever. And then you take it, you have to process it. You take the stem cells, you combine it with PRP, and you inject it. So that's, those are some of the options. So corrective surgery, really important. Okay, so obviously in acromegaly, there's microadenoma, there's a tumor going on. That's not the type of surgery I'm talking about. I'm talking about surgery like, hey, my knee hurts, let me go off and get a knee replacement. My hip hurts, let me go have a hip replacement. My back hurts, let me go have a disc replacement. Let me go have this or that. If you're doing surgery for pain, you're going to be disappointed on the outcomes. All right. Corrective surgery does not correct the problem. It's a misnomer. Remember, I told you the body heals itself, doesn't fix yourself. You're not a car. You can't change that alternator. Okay. There's very specific indications of when you should have a knee replacement, hip replacement, disc replacement. But if it's just for pain, I've had lots of patients who have had knee replacements for pain and continue to have pain. That's where interventional medicine is really taking a hold. Okay. So be careful with that. Now, it does help other people. I'm not saying it doesn't, but just make sure you understand. If you're just doing it for pain, it's a different story. There's very specific other reasons why you should be having it. So, and these are just some of the examples I gave. Now, there are people who have a disc problem. They get a disc replacement or they get a micro discectomy or what have you, and that helps. significantly. That's great. But there were very specific reasons they had that and not something else. So long-term opioids. I want to talk just a couple minutes. How are we doing on time? 30 minutes? Okay. So I want to try to get through the remaining slides in 15 minutes, and that leaves 15 minutes for questions. So there's a lot of talk about opioids, which are narcotics. Narcotics is a legal term. It's not a medical term. Okay. These are opioids, and they've been vilified in the news, right? Everyone on opioids is, you're addicted, shame on you, tons of shaming. First of all, politicians or lawyers, they're not doctors. And I can tell you that in Florida, I get asked to be an expert witness a lot of times in attorneys. I have attorneys who can't even pronounce words, medical words. They're not doctors. But who becomes politicians? Attorneys. And they will grandstand and soapbox. And I have a lot of passion towards this, and I'll try to contain this because it upsets me. I had one patient early on in my career who, he was a 23-year-old that had a crush injury because he got pinned between two cars. And he was working, and he was on actually methadone because he had very bad insurance, and that's all that they could afford. And I was treating him, but he was able to work with this. He was working 50 hours a week, and he was never did anything, was very diligent about it. He came in, drug tested, blah, blah, blah. And so for a couple months in Flint, his insurance dropped use of methadone because, it's a horrible drug. We have this drug issue and this war on drugs. He wrote me a long letter thanking for everything I had done for him. And he shot himself with a shotgun to the head. 23 years old. So I sent that to the Flint Journal. You can imagine they didn't publish it. Let me make this very clear. The media will lie to you when it comes to medicine. I cringe a lot of times when I hear the stuff they say. You are not a drug addict because if you need opioids, no different than a diabetic needs insulin, right? If it's prescribed correctly, managed correctly, and you've arrived to the point where this is what you need, then it's medicine. Okay? You become dependent upon it, no different than a diabetic becomes dependent on insulin. Someone who suffers from high blood pressure is dependent upon high blood pressure medication. Dependency is not addiction. Okay, they have very clear differences, but the media and politicians will use them interchangeably because they have an agenda, because they got to look like they're doing something about anything rather than actually fixing problems. So there's different type of opioids. There's short-acting, long-acting. Long-acting are like extended release. If you're using short-acting ones, which basically only give you about 4 to 6 hours of maximum of or improvement, if you need more than 2 or 3 of those a day, then you should be transitioned to extended release. A lot of academies have put out guidelines about morphine milliequivalents, which is basically they compared all these molecules to morphine. And they say, hey, 90 to 120 milliequivalents of morphine per day is the maximum a person should be on. The problem is, if you need this for life and you build tolerance to this, what do you do then? This is what happens when politics gets involved with science. And unfortunately, a lot of my colleagues were not courageous enough to take their role as leaders and stand in front of community, stand in front of these politicians and say, you're wrong, you don't know what you're doing, and shut up. They failed. And I hope some doctors are listening. Okay? They need to take back control. There's no one in this arena that knows more than I do when it comes to this. And I've said this to politicians. It didn't go over very well. Good thing I'm Cuban and I don't care. Anyways, so there's different types, okay? And there's a whole host of different types. And not all opioids are the same. I gave you a few examples here. Like MS-Con is a morphine. Duragesic patch is fentanyl. Like, you know, if people who have issues with morphine, I can maybe use something like this. And it's not a pill. They have trouble swallowing pills. Or maybe what have you. There's different reasons. Like, for instance, Opana. If you have liver problems, I can use this, right? OxyContin. Everyone hears, oh my God, Pfizer, they're horrible. I don't know Pfizer personally. I don't know if they're good people or bad people, but I can tell you, yeah. And I use Celebrex and a lot of their medications. OxyContin is a fantastic medication for the right patient. I've kept people working for long periods of, for years because they were appropriately managed with OxyContin. Okay. But it's not take as much as you want. It's not that. It's not, I still have pain, let me take more. No, it takes a lot of patient education. Those of you who in the room, and I see a couple who were patients of mine, know we've had lots of conversations about how this is supposed to be used and how to combine this with other medications like the anti-inflammatories, like the nerve medications. You use a little bit of everything to make a soup, right? Not just salt and water. That's nasty. It's called salt water, right? Short acting, different types, all right, like I mentioned. And you can use a combination of these with extended release when you have to. This is not the only way to do pain management. Pain management is a combination of these different medications in combination with these procedures, in combination with lifestyle modifications, in combination with therapies, psychological therapies, physical therapies, okay? So neuroablation, this is the rhizotomy I was talking about. We've come a very long ways. In fact, next week, I'm going to be in Venezuela presenting to the National Congress of Neurosurgeons of Venezuela, talking to them about all sorts of new innovative techniques for using neuroablation. And neuroablation is something you'll hear rhizotomy, you'll hear neurotomy, radiofrequency ablation. And we've gotten very sophisticated with this. So essentially, it applies electromagnetic. Oops, what did I just do? Oh, it uses a form of electromagnetic energy called radio frequency, like a radio, and we apply this energy to a very specific nerve, and it can create a lesion, a very controlled lesion. And by doing this, it can really help significantly with some of the nerve issues going on and subsequent inflammation. And so we can do this for the occipital nerves, for trigeminal neuralgia, low back pain, mid back pain, neck pain, knee pain. I've done this to a lot of patients who have had knee replacements. It can be done for hip pain. I mean, there's a whole host of different things that can be done. So I've done it for different types of facial pain. So shoulder pain as well. So it has, and it's all done through these little cannulas that look like needles. Next, intrathecal therapy. How many of you have heard of pain pumps? Yeah. So you can implant them. Okay, they can be implanted. It has a little tube that goes to the spine. It delivers the medicine directly to the spine. Okay, and you can use, you can actually inject in there different type of substances like different opioids. You can inject different type of muscle relaxers like baclofen. You don't see this too much anymore because there's some issues with the little tubes will kink. You got to every 3 months get it refilled, right? So you get it poked and you know, and if you travel and the machine breaks, you're in trouble. So it's fallen out of favor. There's still a lot of people who put them in and they can be very helpful, but just realize there's some limitations to it. Make sure you're very aware of what those limitations are. Neurostimulation. I got to tell you, this is like Star Trek technology. I do a lot of this. Again, I have no financial whatever with the companies. I worked a lot with like Boston Scientific. I've worked with Medtronic. Those are some of the big players. Essentially, remember I talked about gate theory, how when you grab your thumb, when you hit with a hammer, so your brain can only pay attention to really one stimulus at a time. So essentially what we do with this technology is, first of all, I get to try it out. This is a little device. It's a little computer battery pack. And essentially what I do is first you trial this out, okay? So it basically, through a trial, you wear it for 5 to 7 days. Through a couple of needles, I put in these type of leads in your spine. And you wear this for 5 to 7 days. And you have a little remote control that you saw. And you get to turn it on, turn it off, increase it, decrease it. And basically, this machine can be tailored. It can have multiple programs that can be tailored specifically to whatever's going on. And it can be reprogrammed 1,000,000 times. It's all reprogrammed through a little magnet that sits in it. But during that trial, if we find that you have significant improvement of your pain that you're testing for, then you qualify to have it permanently put in. And then when you have it permanently put in, essentially the little battery pack gets put in, usually in that area. And everything, there's usually 2 incisions, 1 incision there, 1 incision here. And you have that remote control. The drawback is you got to carry around a remote control. And if you piss off your spouse. I had a patient do that once. That was bad. They came back. Oh my God. I'm like, oh, get a lockbox. Gun control. So the amazing thing about this, it can be reprogrammed many, many times. Now, before the big limitation was MRI, you couldn't have MRIs with this. Now you can. Now you can't have 3 Tulsa MRIs. You need a 1.5. Most places use 1.5s anyways, unless you're at a big research institution or something. But that's really the big drawback. Afterwards, you can have a normal life. I've put this in police officers, construction workers, and a couple surgeons. I've put them in one pro athlete, which I can't say their name. I'm not falling into that one. He must be an attorney. So essentially, why I say Star Trek is there's no medication. Basically, what we're doing is we're hacking into the electrical conduits of your spine, how the brain is perceiving pain information, and we're altering it. We're not making you numb. It's not like, oh, I can't feel my leg or it doesn't work. No. We're finding those specific fibers and we're changing the information. And let me tell you, I can tell you some pretty powerful stories. How are we doing on time? Okay. Let me see here. I had a patient. I don't know, this is now 13 years ago, something like that. And so she had bad RSD of both legs, and she was actually an acromegaly patient. And she had, her spine was very, very, very problematic. And that's how she developed this RSD. And RSD is reflex sympathetic dystrophy. And nothing could touch her legs. And in the middle of winter, in January, February, she would come to me in shorts in a wheelchair. Now, if you've ever been to Michigan, I don't recommend going in January or February. It was like negative 20 some degrees. I'll never forget. It was a horrible snowstorm. She comes in and shorts and slips. And I'm like, what are you doing? She's like, I just cannot stand anything touching my legs. And we had tried everything and marginal improvements. We tried for like 2 years. Marginal improvements. We tried so many things. So finally, I'm like, let's try a spinal cord stimulator. And I did the trial in the office. I put it in the trial. And she starts crying. I'm like, oh my God, what happened? And, and she couldn't stand putting her feet on the ground. The pain was excruciating from the touch of carpet or anything. And she's crying inconsolably. I'm thinking, oh my God, something horrible happened. I'm about to call 911, get her to the hospital. I'm about to call the ER. And so she's crying because it's the first time she's not feeling pain in her legs. She gets off my table, and it took about an hour and a half to put it in. She gets off my table and she's like, I want to feel the carpet. As she's walking to the room. And it was such a chilling moment. She was very upset with me when I took out the trial. I'm like, this is coming out. And we put the permanent in. And, thankfully, I only saw her a few other times after that. Yeah. Was she pain-free? No, she was not. But in her mind, she was down to what her 10 was. She lived at a 10, right? What she was experiencing now was negligible, which for most of us, I'm guessing would have been like a 5. But I mean, her legs were molted. I mean, it was very impressive. And within 3 months of me putting it in, her legs, to give you an idea, were completely red, very swollen. They look very spider webby. Within 3 months, her legs almost looked normal. So that was a very powerful testament experience I had. It doesn't work for everyone. The good thing is you do a trial, and this works really well for neck pain, for low back pain, for that radicular pain, so that extremity pain, not knee pain, but that numbness, tingling, burning type pain in the arms and legs. It works very well with, and you get to have it reprogrammed as often as you need, which is huge. Okay. So how are we doing? 15 minutes. Okay. So because sometimes we'll stay here for hours, and I don't want to do that. Yeah. So questions, and I know that she talked about, I promised to answer her question about pain management doctors. So methadone is a big problem in the sense that unfortunately a lot of insurances drive the methadone because it's cheap. And so they're flooded with this, and that's all they can do. And really it's an insurance issue. If you have doctors that only want to treat with methadone, they're not a true interventional pain physician.
Well, in my area, they're prescribing methadone because they're treating,
Addicts.
patients.
Yeah. So
Meth addicts.
so those are not the pain doctors you definitely want to go to, because most of them, yeah. I would tell you, yeah. So I would tell you in that case, you can go to the so the American Academy of Pain Medicine, AAPM website, and you can find a fellowship trained interventionalist. Because the truth is, the interventionalist is not an addiction specialist. And so if pain physicians are working as addictionologists, that's not the doctor you would want anyways.
Okay.
So go to the www.aapm, I think it's .org, which is the
AAPN.
the American Academy of Pain Medicine.
Okay.
Okay. And you can find board certified pain physicians.
Okay.
And you can look at their credentials, and you want to see fellowship trained. And if they talk, and if in their certifications you see addiction medicine, don't go to them. Okay. So what you're experiencing is you're running into a lot of people who are capable of prescribing pain medicine. And that's why they're being used like that. But I have a strong suspicion a lot of them are not board certified pain physicians or fellowship trained pain physicians.
Yes.
And they're addictionologists who also have some training in pain specialty.
I don't know of anyone in my area like you.
Mm-hmm.
The only people I know in my area, the only clinics I know in my area are like what you're speaking of, are addictionologists.
Yeah. Go to the AAPM,
Okay.
AAPM.org, and
Thank
you'll
you
find
very
something.
much.
You're very welcome.
Thank you very much.
You're most welcome.
So they're gonna line up
Sure.
their questions. I need to also, make sure your questions are in the third person. They cannot answer, he's not your treating physician, he cannot treat a patient that's not his own. So, like we've gone over before, make sure your questions are in the third person.
I've got into trouble for it.
Yeah.
Just have you come stand up here. Sure.
Good morning. Thank
Good morning.
You. So I had two questions. Hypothetically, or it's not hypothetical, but basically,
Are you sure you're not
curious.
an attorney?
No, no.
The hypotheticals.
I'm married to one. I sleep with my wallet under my pillow. Yeah. Yeah. I have a lot of good jokes, but that's for later. So is there like a chart that shows various treatment options for each type of pain?
That's a great question. No, there's
Okay.
not.
I'll make it then. That's fine.
Actually, it's interesting you said that, because part of the presentation I'll be giving next week, I created a very simple chart looking at pain complaints per body region and some of the interventional procedures I do for them. But it's not per, like for instance, occipital neuralgia, because the truth is the spreadsheet would be, the matrix would be ridiculously huge, just because there's, if you have one specific complaint, there's multiple things you can do for it.
Use a
But
big
you know what?
sheet of
That's a great
paper.
idea if there was some general format for it. But no, unfortunately, there's not.
Okay. And then the second question I had is there a universal chart, or at least one, that shows like a 1 on pain equals this, a 10 on pain equals that?
When you say equals this,
I'm saying like so to me, a 0, right? Obviously nothing, everything's fine. A 10 is I'm in so much pain, I'm in bed and I'm screaming and I'm banging down and the lights are off and no one can talk to me.
yes.
So, but not everybody, thinks the same way. So I want to be able to be consistent.
Mhm.
And then clearly with a mind towards, I get, some sort of interventional treatment, and the question is going to be, well, what amount of relief did you get, right? So I want to be able to answer that intelligently.
The answer is yes. There are those charts, the visual analog scales, and that little chart I showed you with the little happy faces and a little sad face. Actually, that is from those charts, and they'll tell you the 0 is exactly what you said. 0 is no pain. 10 is the worst imaginable pain. And I usually explain to patients, you'd rather take an ice pick and stab yourself in the eye because that'll feel better than what you're experiencing. That's a 10. And so, but the charts do say that. And there are validated questionnaires that different physicians can use, like a HAG questionnaire and SP30. I mean, so there's different questionnaires that different providers will use.
So
And they
what
can,
do I want to Google to find it?
you can visual analog scale, VAS. So you can just put VAS pain, and then you can look at validated pain questionnaires. And the word validated is very important because these are tools that have been studied, and the specific sensitivities and specificities for these type of pain issues have it's been validated to measure that. So that way, if you want to keep track, like one that I used to use a lot was a HAG, HAQ, and it's basically asks for very functional specific parts, and it basically tallies up to a score, and you can track that score over time.
Awesome. I have other questions, but I want to give other people a chance. So can you just friend me on Facebook or something?
Sure. Actually, you're all welcome to my email. Absolutely. Yeah.
You want to tell us what it is?
Yeah. It's angeljrigueras@gmail.com.
Okay. Thank you very, very much.
Hi. Quick question. If you had a patient who has acromegaly, who has been on hydrocodone, morphine, gabapentin for 10 plus years, who is still suffering from acute daily pain, who has tried the device inserted in the back and had to have an emergency removed because the pain was 10 times worse, who has had the nerve the burning of the nerves in the back, and that relieved pain for about 5 hours and then came back. Would you focus more on treatments as far as stem cell or things like that, or would you focus on the medication?
That's a great question. I wish we had a lot more time because
Right.
I can really go nerd on this.
Yeah.
And I'm a nerd, believe me. The question is both, and I'll try to be as direct as I can with this. So with stem cells, right? You got to be careful. There's a lot of hocus pocus when it comes to stem cells, and a lot of people out there willing to take your life savings, and I think there should be criminal charges against them for that, because they don't have a lot of transparency. When I talked about stem cells, I'm talking about first of all, you can find practitioners who will do that type of technology within a reasonable price range, like a couple thousand, right? And they're not going to tell you need this every month, right, either. And we know that it works well for joints and ligaments. So the problem is a joint and the problem is a ligament. It can help. Two, the medication, like I mentioned, there's a lot of different options. What limits medications is the insurance, right? And that's a big one. So a lot of times, having failed multiple treatments, you could find that your particular genetics, right, the person's particular genetics are such that the way they process that medication, the metabolite from it is not that active. And there's something called pharmacokinetics. Pharmacogenetic studies, which it's basically a swab in your mouth, and they can look at how you metabolize this stuff. And it can help the provider be a little bit more specific. And a lot of insurances will cover pharmacogenetic testing. And basically, they'll look at the enzymes of your liver. Are you a rapid metabolizer? Are you a slow metabolizer? And it can give them a little bit more indication of what group of medications. Maybe, MS-Contin or OxyContin isn't the right way to go. Maybe it's Nucenta, which is a very interesting type medication. In terms of the other thing I would look at is looking at, for instance, if it's more towards back pain, looking at the Cleris, at the Intercept procedure. A lot of people have missed that end plate disease, the inflammation of the end plate. So if you see end plate disease and the MRI, and it looks like those facet joints which you had burned, then all of a sudden maybe it's an opportunity to do the Intercept procedure, and that can help. So you definitely want to look at the pharmacogenetics. You definitely want to look at the opportunity to say, what other things have come out that possibly the treatment wasn't being offered because they weren't out yet. And so those problems were kind of being overlooked because they didn't really have a treatment for it. So that's what I would do. I would look at pharmacogenetic testing, then I would look at possible new procedures such as Intercept. And I would look at the MRI studies to make sure, very likely, there's something going on with her and there's an opportunity to improve it with that.
Thank you.
Hey, Doc. So
Hi.
hypothetically speaking, if I had a patient coming into my office with low back pain, and that patient had been one of the original patients to receive the Medtronic internal, stimulator, and they had to have it removed, like they had it replaced maybe 20 years ago, they had some of the stuff replaced, and then recently they had to have it removed. And they have a lot of scar tissue, which of course is causing them to have a lot of pain still in the low back. Would you actually, because what this patient, hypothetically, their doctor is telling them that they need to do is get that, the intrathecal, and the patient doesn't want that. Would you consider replacing it with the newer
Yes.
internal stimulator?
Yeah, so there's a couple parts to that question. 3 parts. 1, the scar tissue. 2, the intrathecal pain pump. And 3, updated neural stim. So first of all, the scar tissue in the back is essential for the stuff to stay where it's at, especially an older one like the old neural stem from Medtronics. So there's ways to break up some of the scar tissue in the epidural space. With actual medication without getting filleted open, right? Like hyaluronic acid into the areas, and you can go in there with a little camera and start breaking this up. 2, I would opt, to be honest with you, to have it replaced before getting an intrathecal intrathecal pain pump.
That's what I said too.
The new technology is impressive. First of all, it can handle a lot more contact, so it means it can cover more areas, better programming. The programming options are to the point where now it's not about whether you're feeling that numbness and tingling anymore or the stim. They can have sub-perceptive programming where basically it just cancels out everything. So, if you have it replaced, it will break up some of that scar tissue, even though it'll form new one. But the honest truth is, if that was my patient walking in through my door, based upon what you told me, I would be recommending an upgrade. It makes you sound like cyborgs, right? An upgrade to the new neural stem. And now you have such an option. Like I mentioned Boston Scientific just because I really like their product. But the technology is very different now. It's drastically different.
And now, hypothetically speaking, since you practice in Florida, and I also practice in Florida, where are you in Florida?
So I'm part of University of Orthopedic Care. And so we have multiple offices throughout the East Coast. I'm their chief medical officer. So I don't go to all the offices, but I'm in Central Florida and East Coast Florida.
Good, because that's also where I practice. So hypothetically, if this patient were not hypothetical, where could I refer this hypothetical patient?
So the hypothetical patient could see me in Orlando.
Perfect.
And in Samaran.
Yeah.
So
perfect.
on Samaran Boulevard.
Samaran Boulevard. Perfect.
Yep. So right next to La Lochaneta, which is a great Puerto Rican restaurant. So yeah.
I know where that is. Yeah.
Yep.
Okay.
So
cool.
they can come and catch me there.
I will let my hypothetical patient know that.
Perfect. Have them ask for Stacy. I just put Stacy on it. She makes the magic happen in the office.
Hello, thank
Good
you for
morning.
coming today.
Thank you for
really
having me.
interesting stuff. My question is pretty simple. Tell me about meloxicam.
Sure. So meloxicam is an anti-inflammatory. It's also known as Mobic. It comes in 2 different strengths, 7.5 milligrams and 15 milligrams. And basically, one of the advantages of meloxicam is that it has a longer half-life than, let's say, Advil or Motrin. And typically, at 15 milligrams, they state that the half-life can last anywhere from 12 to 16 hours. It can be very helpful for inflammation. Typically, you want to take it for at least 30 days straight with something that helps protect your stomach, like omeprazole or finasteride or something like that. and with food. If you take the 15 milligrams, the 7.5, you do have to end up taking it twice a day. The problem with meloxicam is that actually with the case with any anti-inflammatory is you got to be careful. You got to monitor your blood pressure. All right, because it can elevate your blood pressure. Anyone that has kidney problems really shouldn't be using it for any extended period of time. If anyone has acute or chronic renal failure or has renal artery stenosis as the cause of their blood pressure issues, or anyone who's had any sort of really cardiac coronary problems, want to be careful with that. But I've used it many, many times as part of my pharmacological regimen for treating pain. It works well, and it's actually kind of cheap. In fact, a lot of places, they used to have the old $4 drug menus, like Walmart had some, and that was one of their $4 drugs.
Can it be used in combination with over-the-counter drugs?
Yes, except you want to avoid using it in combination with like Advil, naproxen, Midol, Motrin. So if it says NSAID in the box, that's not what you want to use. But you can use it with Tylenol, right? You can use it as long as it doesn't say NSAID. You can use it.
Okay, thank you.
You're most welcome.
Hi, good morning.
Good morning.
For an acromegaly patient, in reference to like Celebrex, and that patient was told to be careful when stopping that abruptly because of the surge of pain that might come on. Is there a reference as to what that means for the
No.
patient?
So when you look at anti-inflammatories, there's not a lot of literature on rebound pain. Okay. The truth is, if you've been taking it for a while, and this is actually coming more out of the rheumatology patients, especially rheumatoid arthritis patients, they tend to use a lot of Celebrex, right? And so when they've stopped it, we can see how the resurgence, and you can measure inflammation in the body, by the way. There are laboratories to measure inflammation. And so we can see some of these changes in the inflammatory markers. The advice of just stop it and you're going to get this rebound, wow, hit me pain, sometimes does happen. Celebrex comes in various doses, 100 milligrams, 200 milligrams. The maximum dose of Celebrex or celecoxib is 400 milligrams per day. So, if you're on 200 milligrams twice a day, you can titrate down, right? Titrate down from 200 milligrams twice a day to then maybe 100 milligrams twice a day, and then titrate down to 100 milligrams once a day, and then you can go to every other day or stop it. And if you have, after doing that, most people at 7th or 8th day, that's when they really start noticing the increment in pain. And most people tell you, I woke up one morning, oh my God, I was hurting. Or they'll just, and that's more typically what you'll find at that end of the week or at 2 weeks. That's when they start really becoming very aware of their pain again. You can cycle through it. So you can say, okay, I want to take it for a couple weeks on, couple weeks off. Usually I tell people, if you're going to do that, I'd rather see you on 1 month on, 2 weeks off, to give your body a break if that's what they're talking about. If it's the surgeon talking about getting you off Celebrex because they're going to go do surgery, because all anti-inflammatories will essentially, it's a blood thinner. And when you're going to go into surgery, you don't want blood thinners on board, right? So they'll have you typically stop it anywhere from 5 to 10 days before. And that's, unfortunately, you have to look at other substitutes for that. And then after surgery, depending on the surgeon, they may have you restart it a couple days afterwards.
All right, thank you.
You're welcome.
How are you?
Good. How are you?
Good, thank you. Hey, just a really quick question, Mr. Michigan. I don't know if you want me to talk to you afterwards, but I'm looking for an acupuncturist in the Flint, Oxford area.
I don't know anymore. It's been, God, how long has it been now? 6 years,
At
7
least,
years.
okay.
And, I know the pandemic changed a lot. I
Mhm.
still stay very close contact with my partners there. They still have a strong presence, but I do know, actually, a recent conversation with one of my partners. He had told me that, a lot of places closed
Yeah, they
and
did.
haven't reopened. So I don't know, unfortunately. I know that in Lansing, which is about 45,
Right.
50 minutes away, actually in Lansing Township or Delta Township, in that area, there is an acupuncturist that's still present, and he has very close ties to the university.
Okay.
I'm seeing his face, but not his name.
All right.
Yeah,
I
but
just figured if anybody knew.
yeah.
And you're not there anymore, so I can't send
No,
anyone
and
to
the
you,
thing is,
so.
it's changed so much. I mean,
Okay.
people still reach out to me there, and
Okay.
you know, because I had very close ties in the community, as you know, there.
Yeah.
But it's just changed, especially with the pandemic. I don't
Right.
know.
Okay.
Sorry.
That's fine.
Yeah. There is a national organization for acupuncturists, by the way, and I mean, they're professionals who actually have a doctorate in traditional medicine or acupuncture, and they have a national website, and you can Google that national website, and they have a registry of those acupuncturists in the area per zip code. Yeah. Yes, ma'am.
I'm sorry. I'm trying to present the website you gave me,
Uh-huh.
but I think I wrote down wrong.
www.aapm.org, and it should say the American Academy of Pain Medicine. Yep.
So when you go under pain management, it'll be under the website. Wonderful.
Oh. Yeah, you could also go to the AA podiatric medicine or something like that. Also, the other thing is another website is aapmr.org, and they also have a registry there of pain. It's physiatrists specifically, interventional physiatrists. Yeah, yeah. All right. So I don't want to run over. Sorry, because I'm infamous for doing that.
Thank you so
You're
much.
most welcome.
What do you guys think?
Thank you. There could be, I think some of those websites may be here as well. Unfortunately, they're in yellow. I don't know why I chose yellow, but so in there, more than welcome to the
Yeah.
lecture.
And the slides are on our app.
Yeah, the slides are on the app and I'll get them onto the website. So we'll have everything on the website and I'll put this on the pain management page. If you're okay with that.
Yeah.
Yeah, cool.
Thank you so much.
My pleasure. Thank you. And guys, thank you so much for having me. You guys are awesome.